Hi everybody, I am Dr. Priti Anand, and today I'll be covering some important questions related to the contraception and the STIs. So just starting with a small quote, keep your energy focused on your goals and your dreams. So my first EMQ is, first of all, the most important thing for any EMQ, as we have discussed in our previous lectures also, always read the lead statement. Okay. So they are asking you the best emergency contraceptive option in the following scenarios. So 22-year-old woman, para 2, presents to emergency department at hospital at midnight. She has a history of condom rupture while having an intercourse 3 years ago. She's on regular progesterone only pills. Her LMP was 1 week ago. She missed 2 last pills. Okay. And she is worried about getting pregnant and her parents will abandon her. And she does not want that. And she is asking for emergency contraception. For the patients who are on progesterone only pills, if they have missing of even one pill, because the progesterone only pills, the traditional pills like norethistérone has a very small window period of 3 hours. So if they are even delayed for 3 hours, here she has missed for 2 days, 48 hours, then it is considered to be the missed pills. And if she has missed the pill and she had an intercourse after missing of pills, then she requires an emergency contraception. So ideally, the best contraceptive for such patients, for any patient, is always a copper coil because it is highest in the efficacy. So the best thing you can offer her is to have a copper coil. And as I told you, missing of POP pills, if more than 3 hours for traditional pills, more than 12 hours for gestural pills, always require, and has an intercourse, unprotected intercourse after that, requires a emergency contraception. Moving on again to the next set of same EMQ, 28-year-old misses 2 consecutive pills from the second week of her pill taking of combined pills. Okay, so day 9 and day 10 she has missed. She has been regularly taking the pills on day 1 to day 7. As you all know that COCs are taken for 3 weeks, then 1 week is a gap, whereas POPs are taken continuously without a break. So she has forgotten the pills in the week 2 and 2 pills she has forgotten. She had intercourse with her boyfriend on day 8, and she wants the advice for EC. So missing of 2 pills after the intercourse, first thing, and taking the proper pills for first 7 days, always say that she does not require any emergency cover. Okay. So any patient with the combined pills who has missed any one pill in any week. Okay, only one pill has been missed. 24 hours missing has been there, less than 48 hours, you can say. One pill missed or patch or ring problem. Then she requires nothing. Nothing, only take the most recent pill at the normal time. No EC, no emergency contraception. If there has been missing of 2 to 7 pills in the week 1 of taking, she requires an additional cover. She requires taking the most recent pill, rest of the pill at usual time. And if there has been EC, she requires there has been UPSI, she requires an EC. Whereas in week 2 and week 3, even if there has been a UPSI and she has taken first 7 days regular pills, no EC is required. For more than 7 pills missing, always it is missing, like starting it as a new packet. So if there has been UPSI, you consider doing up UPT. You can start the new packet with additional cover and EC as required. Patient on POPs, 3 pills has been missed. There is history of UPSI after missing of pills. Her BMI is 35. She visited you for emergency contraception. She wants to resume the POPs as soon as possible and her chlamydia test is positive. Now you have to again tell the most important, most best treatment for the emergency contraception. Now because her chlamydia test is positive and we also know IUD is always the best option, we can't give IUD here. Now with POPs, second best, UPA is also a problem because UPA is an anti-progesterone. So if you are giving UPA, somewhere the progesterones in the blood levels will affect its efficacy. Similarly, if you want to start POP immediately, the efficacy of POPs will also be affected by UPA. So both the things are at a problem. So she's only left with one option, that is LNG oral pills. Now, one very important thing over here is she's having a BMI of 35. So LNG with the BMI of 26 is okay to give in a standard dose. But if the patient BMI is more than 26, she requires a LNG in the double dose. A 24-year-old woman, her husband has having an intercourse with condom tears. She's planning for the woman attends the family planning 3 days later. She's worried about that she will get pregnant because she does not want children for at least 5 years. She's asking for emergency contraception. Otherwise, fit and wealthy. She has delivered Sarah 2 weeks ago. What advice you will give her? So basically, this patient is in a postpartum phase. Okay, postpartum 14 days has been elapsed. So any patient in the postpartum phase up to 21 days postpartum, she is protected herself protected without any cover, without any contraception from unwanted pregnancies. Okay. So till 21 days, even if she had UPSI, she do not require any contraception. Okay. A 36 years old Ellie delivered 27 days back via cesarean section. She is otherwise fit and well. She has a history of UPSI to 48 hours ago. She's breastfeeding the baby. She wants EC. What is best suited for her? Now, again, this is a postpartum patient, but 27 days after the postpartum period. Otherwise fit and well, 48 hours of UPSI, breastfeeding, not formula feeding. She's exclusively breastfeeding, wants EC. So after delivery via cesarean normal delivery up to 21 days, patient do not require any EC. But with the copper coils or any type of intrauterine devices are not given up to 28 days postpartum for any patient. So even though copper coil is the best EC, you can't give her because she is still 27 days postpartum. Now you're left with UPA, which is the second best, and LNG. So can you give UPA? So patients who take UPA has to avoid breastfeeding for 1 week. And now because she's exclusively breastfeeding, you can't do that. So this patient is a candidate for LNG and a standard dose of 1.5 milligram. 18-year-old woman attends the family planning clinic. She is very anxious because she had unprotected intercourse with stranger 2 days ago. She is worried that she will get pregnant, which she is not be able to come to the clinic before this. She has epilepsy. She's on phenytoin. She's on day 13 of her regular cycle, does not want coil. What contraceptive will be best suited for her? Now, again, the best is always coil, and day 13 means she's in a pre-ovulatory phase. So definitely oral ECs can be given or copper coil, but copper coil is best, which should be offered to her, but she does not want that. Now you are left with oral ECs, LNG or UPA. Now because she's on a phenytoin, which is an enzyme-inducing drug, again, UPA can't be given at all. LNG also ideally should not be given with the enzyme inducers. But if nothing option is there, you can give LNG, but in a double dose. So these are the one of the table. If you remember in your exam, it will be very easy to solve the emergency contraceptive questions. Okay. So copper coil can be inserted 120 hours up to UPSI. Same is UPF, and LNG is up to 72 hours. Copper coil is the best, followed by UPA, followed by LNG in preference to efficacy. Copper coil is the only one which can be given after the ovulation has happened because UPA and LNG work mechanism of action is delaying ovulation. So after ovulation, 5 days after estimated days after ovulation, you can get copper coil. Effect of weight, it's not effective, copper coil. UPA is ineffective if the weight is more than 85 or BMI is more than 30. LNG is ineffective if the BMI is more than 26 or weight of more than 70. But if you need to give, you need to give it a double dose. With enzyme inducers, copper coil, they have no issues. UPA is avoided, not only with enzyme inducers, but also with PPIs and glucocorticoids. And LNG also avoided with enzyme inducers. But if nothing can be given and LNG's only option can be given in a double dose. Copper coil after delivery can't be given up to 4 weeks. UPA better avoided if the patient is breastfeeding, but can be given anytime after delivery. LNG, no contraindication as such. Now, the second set of questions says, what is the best treatment option for the scenarios? So there is a female, presents 10-day history of malodorous vaginal discharge, denies any fever, chills, pruritus, dysuria, pain during sex or pelvic pain. She is 24 weeks pregnant, uncomplicated pregnancy so far. She engages in vaginal sexual intercourse with one partner, that is her husband, and she's in a monogamous relationship from past 5 years. She's diagnosed with bacterial vaginosis. Now she's 24 weeks pregnant with bacterial vaginosis. What should be the treatment? Ideally, the treatment of choice for bacterial vaginosis is metronidazole. As far as possible, in pregnant patients and lactating patients, specifically in lactating patients, oral drugs should be avoided. But oral 400 to 500 milligram twice daily for 5 to 7 days, which is a normal regime, is a best option. 2-gram start dose is never a best option. But if you see in these questions, in these options, sorry, you will see that metronidazole oral preparation option is not there. So what you can do, you can give her a gel. 0.75% of gel, one full applicator, 5 grams intravaginally once a day for 5 days. So bacterial vaginosis treatment for choice is metronidazole 400 milligram twice daily for 5 to 7 days. 2-gram single dose better avoided in pregnant patient, or intravaginal course of metronidazole can be given. And it is safe in pregnancy also. So pregnancy metronidazole is okay to give, but tinidazole should be avoided. So pregnancy, you treat the patients who are symptomatic, who are asymptomatic, but they carries the risk factors for preterm birth. Taste of milk may be altered by oral metronidazole, so better avoided in specifically, as I told you, oral preparations, specifically the 2-gram start dose to be avoided both in pregnancy and breastfeeding. And because it is not a STI, so treatment of cure, test of cure and partner notification is not done. 29-year-old, 5 days history of vaginal itching, redness, thick white discharge, denies chills, fevers, pelvic pain. She's 25 weeks pregnant in the first pregnancy. She's in a monogamous relationship with uncomplicated pregnancy right now. And it is preparation of vaginal discharge shows that it is candida, basically yeast and pseudo hyphae. What should be the treatment? So for the bacterial vaginosis in pregnancy, for the candidiasis in pregnancy, the treatment of choice is always a intravaginal suppositories. Okay. If that is not an option, then you can give 10% cream, 5 gram intravaginally daily for 7 days. Otherwise, the best option is for the patients who are pregnant is clotrimazole passeries, 500 milligram intravaginally for 7 consecutive nights. But because that was not an option, we choose it for the vaginal cream, clotrimazole vaginal cream. Third question is 26 years old female. Health, she presents to the health department having unprotected intercourse 6 weeks prior, requests a pregnancy test which is positive. Based on her LMP, she is 18 weeks now. Consents for STD screening. 2 days later, the health provider notifies that she's been tested positive for chlamydia. Now, in pregnancy, the chlamydia treatment can never be doxycycline, because ideally the treatment for chlamydia in general is doxycycline 100 milligram PD for 7 days. Because doxy can't be given, so the next best option for this patient is usually amoxicillin, okay, or it can be erythromycin. Akila, can we stop for a moment?
Yeah, ma'am.
Yeah, just a moment. So the next patient is a pregnant patient. Okay, she's 18 weeks in pregnancy, and she consents for STD screening, and she's found to have chlamydia test positive. Now, in pregnancy, chlamydia, if positive anywhere, time if it is positive, we need to treat her. Because chlamydia, the standard treatment is doxycycline, which is contraindicated in pregnancy. So either you have to give amoxicillin, erythromycin, but if you see into the chart in the options, amoxicillin and erythromycin are not given as a proper dosage schedule which should be given in pregnancy. So we are only left with azithromycin 1 gram oral single dose followed by 500 OD for next 2 days. So if you in general see chlamydia has to be either amoxicillin 500 TDS for 7 days, and if you can see it is BD here, okay. Erythromycin 500 4 times for 7 days, or 500 twice daily for 14 days. So here it is 4 times for 21 days, which is an incorrect option. Okay. So that is why the answer over here is the last option, azithromycin 1 gram oral in single dose followed by 500 OD for 2 days. Otherwise, these are the better option. Azithromycin is always a last option. Lastly, the EMQ includes 24-year-old women who comes to A&D with lower abdominal pain, abdominal discharge, bleeding, postcoital intermenstrual bleeding, menorrhagia, temperature. Bimanual examination shows adnexal tenderness, cervical motion tenderness. She's pregnancy test is negative, diagnosed with PID and requires a recommended regime. Okay. So because it is always a broad spectrum cover and because she is pyrexic, so she requires an admission. So admit her, give her ceftriaxone 1 gram intramuscular for gonorrhea, followed by the oral doxy and metro for 14 days, for rest of the 14 days to cover the whole treatment. Okay. But because she is pyrexic, uh, Akila, I need to stop it again, dear. Just a moment.
Amen.
Sorry. So the next patient is full-blown patient with signs and symptoms of lower abdominal pain, vaginal bleeding, abnormal bleeding, and intermenstrual and postcoital bleeding with pregnancy test positive, full-blown signs and symptoms of PID. Because she does not have any symptoms that she requires an admission, so she can be taken with the outpatient management of PID, given ceftriaxone 1 gram intramuscular stand and followed by oral doxy and metro for 14 days. Okay, she's not pyrexic also. Otherwise, her symptoms and signs will give us the picture of PID. So if there is a PID patient and who can tolerate and is not having a pyrexia, emergency, TOAPSIS, pelvic peritonitis, intolerance to oral drug, pregnancy, or any surgical emergency, can be treated with the outpatient regime. If any one of these inpatient requirement is required, she will be admitted and at least till she is 24 hours symptom free, and thereafter she can be shifted to oral medications. But for that period, she requires an admission. Starting with some of the very important SBAs, Mrs. XY is 35 years old, copper IUCD in situ, presents with the colposcopic clinic with a smear showing ALO. She has no complaint of pelvic pain, dyspareunia, vaginal discharge. She is not sexually active and wants the best treatment option for her. Now, because ALA is considered to be the normal commensal of vaginal flora, so sometimes on the spheres you can get it. But if the patient is absolutely asymptomatic, it's nothing to worry about. So you do not require to give her any treatment. You do not require to remove the device as well. If the patient is symptomatic, she might require an antibiotic cover. Chlamydia trachomatis is associated with all of the following except it is an obligate intracellular virus, except that means you have to tell the false statement. All are true except. Obligate intracellular virus, it can cause conjunctivitis in newborn. It can cause pneumonia in newborn. It is a causative organism for lymphogranular venerum, and it is transmitted to the newborn during its passage through the birth canal, may cause conjunctivitis and pneumonia. So I think it's the first is absolutely wrong because it's not a virus, it is a bacteria, and rest seems to be the correct options. 20 weeks gestational age, lady came to because husband is diagnosed with HIV. Her booking tests were negative for HIV. Now what to do? Because bookings are usually done between 7 to 9 weeks, and repeat testing should always be done 3 months after the first test. Okay, so you can calculate it accordingly, and if she has been already 3 months after that, right, in this case, so you can repeat the test now. 12 weeks. 14 weeks pregnant, HIV infection, starts on card therapy and wants to test her viral load in order to monitor her adherence to the treatment. So once you start any patient of HIV the card therapy, ideally first time you have to check the viral load 2 to 4 weeks after starting the card therapy, then at the each trimester, then at 36 weeks and at the time of delivery. 25-year-old G2P1 books at 24 weeks and her booking blood test shows that she is HIV antibodies, which were later confirmed by PCR. CD4 count is 900. She was started on card. Her fetal anomaly scan is normal. Appropriate advice for postpartum. So for the postpartum, any patient who has started card therapy in pregnancy, they will be meeting the HIV specialist 4 to 6 weeks post-delivery. Okay. So till that time, until unless they meet the consultant, the specialist, they have to continue their card therapy. They don't have to stop based on viral load, based on CD4 count, anything. Okay, so continue during delivery and review with the HIV specialist postpartum. 30-year-old, 36 weeks pregnant to the antenatal clinic. This is a first pregnancy. She's HIV positive, fully compliant with the heart therapy throughout the pregnancy. Her latest serum viral load was more than 500 copies. Apart from HIV, her pregnancy has been uncomplicated and appropriate loan cephalic presentation baby delivered by cesarean section. For how long the treatment of the baby should be continued. So post-exposure prophylaxis for the baby depends upon the maternal condition. So if she has a very high viral load for which she went a cesarean section, the the baby will require a triple regime for the post-exposure prophylaxis. So zidovudine, lamivudine, and nevirapine should be given for 4 weeks. So postpartum, the baby is assessed as very low, low, and high risk. Very low means the woman was on cart therapy for longer than 10 weeks during pregnancy. Her two HIV viral loads were less than 50, 4 weeks apart, and her recent viral load were also less than 50. If that is fulfilled, the baby is at very low risk, given her 2 weeks zidovudine therapy. Low risk babies, any one of them are not fulfilled, but still at the time of delivery, the mother's viral load was less than 50. So 4 weeks zidovudine monotherapy has to be given. And if the viral load of the mother is unknown or higher, more than 50, the baby will always require a triple regime of post-exposure prophylaxis, zidovudine, lamivudine, nevirapine for 4 weeks. Woman on cart therapy and induction of labor was done at 41.4 weeks. She's on cart since 12 weeks, delivered and earlier her viral load was less than 50. What measures should be taken to avoid the vertical transmission because she's already undergoing a vaginal delivery. So cart she must be already on. So two things which you have to make sure that you have to avoid the breastfeeding, and secondly, you have to give the baby 2 weeks of zidovudine monotherapy because baby is considered as a very low risk here. The same thing which we have just discussed. A 30-year-old, 36 weeks pregnant, antenatal clinic. She's in the first pregnancy, HIV positive on heart therapy. Her viral load is less than 50. Apart from HIV, her pregnancy is uncomplicated. Cephalic presentation baby is there, and she's concerned about the vertical transmission to the baby. Which of the following is recommended? Because she is having viral load of less than 50 copies and she's compliant with the heart therapy, you can offer her vaginal delivery. Okay. In that case, we do not induce the patient at term. We just wait for spontaneous onset of labor pains and let her go into the labor. Okay. So if viral load is something at 36 weeks, which will decide the mode of delivery. If they are less than 50, patient can undergo vaginal delivery. It is 50 to 399. Planned cesarean section should be considered. And if it is 4400 and above, then always planned cesarean section should be considered recommended between 38 to 39 weeks. An Asian woman, 22 years old, conceived on intrauterine pregnancy, diagnosed at 7 weeks of period of gestation, successful copper T insertion 44 months ago. Her pregnancy test is positive. Urgent ultrasound shows that it is a gravid uterus with 7 weeks pregnancy and copper T device is visible. But this thread is not there because she couldn't feel it. And stem is there in endocervical canal. So what to do if she wants to continue the pregnancy? So ideally what they say is if the patient conceives with copper coil in situ and she wants to continue the pregnancy, it has to be removed by before 12 weeks. Okay. So because she has come to you and she is before 12 weeks, you can remove the device now. The problem here is threads are not there, but stem is still visible in the endocervical canal. So you can pull it out. Sometimes if thread is not visible, okay, or if the stem is also not visible, then it depends upon you have to discuss with the patient whether we can try removing it or not. Because in both the conditions, if we continue also, it's a risk to the baby. If she does not continue also, then also, if she decides to keep the device in situ, then also there is a risk. And if you decide to remove, then also there is a risk of abortion. Okay, that you have to explain if there is no thread and the no stem is approachable. Lastly, the efficacy of some anti-epileptic drugs are reduced by oral pills. Usually it is other way around because enzyme reduces the efficacy of oral pills. Now here the condition is oral pills are reducing the efficacy of which anti-epileptics. So I think everybody knows it is lamotrigine, which efficacy is decreased, and definitely it will increase the seizure frequency if the patient is on COCs and lamotrigine. Lastly, they are asking you that the patient has signs and symptoms of pelvic pain and discharge, and they want to know what is the best test to confirm that it is chlamydia. So it is always lower vulvovaginal swab, and the test which is done is a NAT test, which is done for the patient to confirm whether the patient has a chlamydia or not. So thank you guys. This is one of the tables which can help you revise the Neisseria, chlamydia, and mycoplasma in a quick go. So have a look into this table and remember for 3 of them, the best test is a vulvovaginal swab taken and the test which is done is an NAT test. So thank you, and I hope this lecture was helpful to everybody. And we are looking forward for you to joining us more and more. And if you have any doubts, you can comment, and I'll be really happy to answer everything. Thank you so much, and have a nice day.